Okay, we're back. In this section of the discussion, we're going to talk about full thickness lesions. Full thickness lesions are typically ischemic lesions that start in the deep tissues, usually at the muscle-bone interface, and they're typically caused by pressure or a combination of pressure and shear. So what did we say in the previous class? We said that partial thickness lesions involved partial loss of the skin layers, that full thickness lesions involve total loss of the skin layers with extension into the subcutaneous tissue and possibly into the muscle or bone. What are the characteristics of full thickness lesions? Well, first of all, they're obviously deeper, so they're greater than 0.2 centimeters in depth because they involve total loss of the epidermis and dermis. Typically, you have some degree of crater formation. The crater can be shallow, it can be very deep, depending on tissue layers that are lost and also on the patient's body weight. So if you have a bariatric patient, a full thickness lesion can be very, very deep. Whereas if your patient is very thin, even cachectic, you might have a relatively shallow crater, even if it extends into the muscle. Very common to have tunneling or undermining. Those are terms that we'll talk more about. Particularly common when shear force is involved in the pathology, and we'll go over that in a few minutes. Also very common to have necrotic tissue, either slough or eschar. That makes sense because what did we say? We said that most of these wounds were caused by ischemic pathology, pressure and or shear. So you get loss of blood flow to the tissues, you get tissue death, and that manifests as necrotic tissue. So looking at the pathology of full thickness wounds, we've said they typically involve pressure and or shear. Where are you going to find these wounds? You're going to typically find them over bony prominences because that's where soft tissue gets compressed between the bone internally and the bed or chair or cast or splint externally. So you get soft tissue compression, you get vessel compression, you get tissue ischemia, tissue death, and a large wound. Now we are going to talk at the end of this section about medical device related pressure injuries, and those will be a little bit different because the pathology is a little bit different. So we'll talk about them separately. Right now, we're talking primarily about full thickness wounds that occur over bony prominences as a result of pressure or pressure in combination with shear. Now, why is it that pressure and shear injuries cause full thickness tissue loss that typically originates in the deep tissue? Well, first of all, you have to think about the fact that you have compression of all soft tissues. So you have a patient in bed, you have a patient in the chair. Think what's happening. All the tissue layers are being compressed between the bone and the chair cushion or the mattress on the bed. Skin, epidermis, dermis, subcu, muscle, all layers compressed. So you're going to get reduced blood flow to all tissue layers at once. And then you have to think, well, which tissue layer is most susceptible to hypoxia, to ischemia? Which one's going to get into trouble first? It's not the epidermis. The epidermis is primarily composed of dead cells anyway, so can't kill them, they're already dead. Epidermis is very resistant to the effects of pressure. What about the dermis? What about the subcutaneous tissue? Those tissue layers are very stable from a metabolic standpoint. So they do not use oxygen at a very fast rate. They use oxygen at a very slow rate. What about the muscle? The muscle is the most metabolically active soft tissue layer because think about what muscles do. They maintain body position. They're responsible for changes in position. So they're using oxygen. The muscle cells are using oxygen at a much faster rate. So if I cut off blood flow or reduce oxygen levels to the epidermis, to the dermis, to the subcu, to the muscle all at the same time, It's the muscle layer that will get into trouble first because it's using oxygen at the fastest rate. So it's the most vulnerable to any degree of tissue ischemia. Also, studies have shown that the pressures at the muscle-bone interface are consistently higher than pressures at the skin resting surface interface, because that's where the bone interfaces with the muscle and you get a lot of muscle compression. So that means that right here where you have the highest pressures, you have the greatest interference to blood flow, and that's exactly where the muscle lives, and the muscle is the most vulnerable to hypoxia. So this layer gets the greatest interference to blood flow, and this layer uses oxygen at the fastest rate. Not surprising that ischemic injury from pressure and or shear begins almost always at the muscle-bone interface. And that's what all of these little slides are showing you. First of all, that the tissue overlying bony prominences is the most vulnerable to the effects of pressure and shear because that's where the soft tissue is compressed between the bone internally and the resting surface externally. Highest pressures right here. You exert the pressure. We're watching to see what happens at the skin surface. In reality, the pathology is occurring right here. So what are the characteristics of pressure shear injuries? What do we see clinically when we go to turn the patient over? Well, first of all, as we've said, we see crater formation. Typically, we see extension to the muscle or even the bone. If the wound is caused by pressure alone, the wound will be round or very slightly oval, and there will be minimal tunneling or undermining because pressure is exerted very evenly in the underlying tissue. And the ischemic effects will mimic the shape of the tissue that's under pressure. Now, if you have a combination of pressure and shear, you can have an elongated wound, you can have a wound with irregular edges. It's very common to see tunneling and undermining. Why is that? Because while pressure is exerted evenly, shear can create damage in any direction because shear involves distortion or total compression or tearing of the blood vessel. When you get that, you can get tissue damage that occurs wherever that vessel supplied the tissues. We'll come back to that. So the major etiologic factors for these deep wounds, these full thickness wounds, due to pressure and shear, obviously either prolonged pressure or very intense pressure. That's an extrinsic factor, okay? That's an outside-in factor. Shear force, and we'll talk more about shear force, another extrinsic factor. And then compromised tissue tolerance, meaning that some patients are higher risk for pressure damage because they're very thin and they can't evenly distribute pressures because they're febrile and they're using oxygen at a faster rate because they're hypotensive, and even at baseline their tissue perfusion is compromised. Many things that would render a patient much more vulnerable. So compromised tissue tolerance and intrinsic factor. We've already talked about the fact that these wounds are bottom up. Ischemic injuries are bottom up. They start deep tissue, okay, muscle-bone interface, and then they gradually come up toward the skin. So we're going to spend a little bit of time talking about exactly what happens to tissue that is under pressure, exactly what happens when tissue is exposed to shear force. And then we're going to spend some time talking about, well, how do we protect the tissues from pressure? How do we protect the tissues from shear force? So let's talk about normal tissue perfusion. And of course, you know all this. You know that you have the arterial system, the venous system, the lymphatic system. You know that the arterial system, you start out with big arteries, smaller arteries, then eventually arterioles, then the capillary bed, then the venules, smaller veins, larger veins, big veins. But the end point of the circulatory system is the capillary system. And that's the critical point, because that's the point at which oxygen and nutrients are exchanged for gas, for carbon dioxide gas and waste products. So it's the capillary bed where everything happens. If we compress the capillary bed, if we stop blood flow at the capillary level, we are compromising perfusion to the tissues. We are compromising oxygenation of the tissues. We are compromising the ability to eliminate waste products. So if you think about it, if you compare it to any kind of delivery system, let's say the FedEx truck picks up everything from the distribution center, gets all the way through the interstate, through the big surface streets, down to your neighborhood, and then something happens and it never makes it to your street. Let's say the street's blocked by a tree or whatever, and the FedEx truck can't get through. Then whatever it is that the FedEx guy is trying to get to your door never gets there because the smallest street was blocked. Same thing with tissue perfusion. Even if the big arteries are open, everything's fine at the level of the aorta and the large vessels and even the mid-sized vessels and even the arterioles. If we get compression of the capillary system, we shut down or significantly reduce tissue oxygenation, shut down or significantly reduce the body's ability to retrieve waste products and carbon dioxide. So what do we know? If you have prolonged pressure or if you have very intense pressure, you can either obliterate or significantly reduce blood flow through the capillary beds. So when a patient is sitting in a chair for a prolonged period of time, or if a patient is sitting on a very hard surface, like an x-ray table, even for a short period of time, think about what happens to those soft tissues. They get compressed. Think about what happens to the blood vessels running through the tissues. They get compressed. Think about what happens at the level of the smallest blood vessel. The capillaries get collapsed, either totally or partially, and the volume of blood going through is reduced. Tissue oxygenation is reduced. So either prolonged pressure or intense pressure. I wanted to spend just a minute talking about the difference. If you have intense pressure, so that's like when you're sitting on a hard surface, you're lying on an x-ray table, you're in interventional radiology, you're sitting at your kid's ball game on bleachers. A rigid surface causes high-level tissue compression, high-level interference to blood flow, and rapid onset of tissue ischemia. Now let's take that patient off the x-ray table and put them in a hospital bed or put them in a wheelchair with a cushion. So now there's some tissue compression. It's not nearly as severe, but it's enough to partially collapse the capillary bed. So some blood flow is still going through, not nearly as much as normal. But the capillary is not totally collapsed. It's partially collapsed. So you've got some blood going through, some oxygen going through, some waste products being returned, but not nearly enough. And over time, the tissues build up an oxygen debt and become increasingly ischemic. So the point is, tissue damage can occur from high-level pressure over a short period of time, sitting on the x-ray table, lying on the x-ray table, any hard surface. But tissue damage can also occur from moderate level interference to blood flow that persists minutes, hours, while an oxygen debt builds up and the tissues become progressively more compromised. Now look at this. A major question that's been asked has been, well, how much external force does it take to collapse the capillary bed and stop perfusion? And we don't really know. Studies have shown that in most individuals, it's about 17 millimeters of mercury. But go back to the previous point. If that person is lying on an x-ray table on a hard surface, the external pressure will definitely be greater than 17 millimeters of mercury. The capillary bed will be collapsed and you'll have almost instantaneous obstruction to blood flow and cessation of blood flow. So you'll have very rapid onset of tissue ischemia. That doesn't happen nearly so often as the scenario where the patient's sitting in the wheelchair on a cushion for a prolonged period of time, or lying in bed on a pressure redistribution mattress for a prolonged period of time. Sitting in the wheelchair on that cushion, partial obstruction to capillary flow. We do not have capillary closure. The capillary is still partially open, some blood's getting through, but not as much as normal. So it's like taking 2 to 3 lanes out of a 4-lane highway. So yes, some blood's getting through, some oxygen's getting through, but remember what's happening. Diminished perfusion, progressive oxygen debt, progressive ischemia. Patients can get into trouble from either scenario, from either very high level pressures over a short period of time or for moderate level pressures over a prolonged period of time. We'll keep coming back to that because those are both pathways to tissue injury, and we have to pay attention to both of them. Now, this is a very important point. Your tissues can tolerate short-term occlusion. So I'm back to you're going to your sons, your daughters, your grandsons, your granddaughters' ball game, and you're sitting on hard bleachers. You're going to sit there for 2 hours, 3 hours, but when you leave, you won't have tissue damage. Why is that? It's because of 2 facts. Number one, your tissues can tolerate short-term interference to blood flow because soft tissues use oxygen at a slow rate. So yes, you can tolerate short-term occlusion. Here's the second thing. We're all equipped with a pressure ulcer prevention system. As long as you can feel and as long as you can move, you will self-protect. So think what happens when you're sitting on those bleachers. Pretty quickly you get uncomfortable because that high level pressure shuts down blood flow. The tissues become rapidly ischemic. Ischemia hurts, so your tissues send a message to your brain that says, please shift your butts. And you do so. And immediately blood flow is restored to that area and cut off to another. So in just a little while, the new site is going to say, get off me, and you'll respond. So see how we self-protect? We recognize tissue ischemia because it's uncomfortable, it's painful, and we shift so that we restore blood flow to that area. Think about times when you have rolled over on your arm while you were asleep, and pretty soon your arm's asleep too. But do you ever wake up in the morning with just one arm because this one fell off because you didn't get off of it? No. Because as this arm becomes progressively more ischemic, as the tissues become more ischemic, you get progressively stronger messages, move, and it will wake you up out of a very sound sleep. And you'll hold your arm out and you'll be like, can I do anything with my fingers? No, you can't do anything with your fingers because the muscles are ischemic. The nerves are ischemic. And then what happens? You start getting that tingling, that very uncomfortable sensation as perfusion is restored to the nerve pathways and the muscle. and then gradually you regain function. That's the tissues recovering from that period of ischemia. So as long as you can feel, as long as you can move, you will self-protect. What does that tell you? Which of your patients are at risk? People who have lost sensory awareness, like your cord-injured patients, you're a diabetic with neuropathy, patients who have lost mobility. Those are our high-risk patients. Those are the people we have to protect. Okay, so looking at pressure injury pathology, we've already said that either sensory impairment or impaired mobility or some combination of those two things results in prolonged or intense pressure. You get blood vessel occlusion that causes progressive ischemia of the tissue. So you can get total occlusion with rapid onset of ischemia. You can get partial occlusion with gradual onset of ischemia. You have to think about the fact that the lymphatic vessels are occluded as well, and that results in progressive edema of the underlying tissues. What does edema do? It further compromises perfusion, so you start getting into this vicious cycle. You also will have to look at reperfusion injury. That's come under a lot more study recently. We're starting to realize that pressure injuries are more complex than we originally realized, and that reperfusion injury is probably a significant component of the equation. So what happens with reperfusion injury? Think about the fact you've got vessel compression. So blood is not flowing through at the normal rate. It's either not moving at all or it's moving very sluggishly through this very narrow vessel. As a result, what starts to happen? You start to develop little microthrombi. Then you restore blood flow. And what happens? The microthrombi move downstream to smaller vessels and cause occlusion, starting the whole cycle of tissue ischemia again. In addition, in the presence of hypoxia, you get development of oxygen-free radicals, which are inflammatory substances that are damaging to the endothelial lining of the vessel. That is another factor contributing to reperfusion injury. Now I want to talk about the inverse relationship between the intensity of the pressure and the time required for damage. And we've already been talking about this. So we said if you have very high level pressure, you get total collapse of the capillary bed and rapid onset of ischemia, rapid onset of tissue damage. We also said that if you have moderate level pressure, you get partial occlusion of the capillary bed, so you get reduced blood flow, gradual development of ischemia, gradual development of that oxygen debt, and a slower onset of tissue damage. So either high level pressure for a short period of time or moderate level pressure for a prolonged period of time can lead to tissue ischemia, tissue death. Okay, so here's this represents the inverse relationship. High level pressure is going to be tolerated for only a very short period of time before you get into damage. As the intensity of the pressure comes down, the time tolerance increases. So major implications for us in terms of prevention. We want to intervene to reduce the intensity of the pressure exerted against the soft tissues, and we want to intervene to reduce the amount of time that those tissues are going to be compressed. How do we do that? How do we reduce the pressure intensity? We use support surfaces. We use cushions in the wheelchair. We use mattresses on the bed that are designed to evenly distribute pressures to reduce the pressure intensity. Same thing as stadium seats. So you think about sitting on wood bleachers or concrete bleachers. Very rigid surface, total compression of the soft tissue, rapid onset of ischemia. If you take a stadium seat, now you have some padding between you and the concrete. And so now the pressure is distributed a little bit more evenly over your buttocks, and it buys you a little bit more time before the tissues start to get ischemic. If you have several kids in sports, you might buy the Ultra Deluxe stadium seat that has more padding, more cushioning, that allows you to sink into the cushion, weight very evenly distributed, and you can sit there maybe 20, 30 minutes before you get uncomfortable. When we put a patient on a pressure redistribution surface, what we do is we evenly distribute the pressure across the entire contact area. So instead of the patient's weight being supported only by his or her bony prominences, now his or her weight is supported by the entire mattress surface. Weight's distributed evenly. There's a marked reduction in point pressure, marked reduction in interference to capillary flow. Buys the tissues a lot of time before they become ischemic. So surfaces in general are designed to reduce pressure intensity and buy the tissues more time. What about repositioning? What about when I go in and I turn the patient from his or her right side to his or her left side? Then I've totally offloaded pressure from the right side, so perfusion is totally restored. So we can work both on the pressure intensity side of the equation, we can work on the time side of the equation. We use surfaces to reduce intensity, we use repositioning to reduce the time factor. Now, a couple of other things we should go over. We should talk about the impact of repeated episodes of pressure, and say repeated episodes of some degree of tissue ischemia. So let's say it's the weekend, it's a crazy weekend, we've all had those weekends. We get a patient up in the chair at 10 a.m., we mean to get them back around noon. Physical therapy gets tied up, we're tied up, there's a code, crazy. It's 3, 4 o'clock before we get them back to bed, and we're like, oh my gosh, that's 5, 6 hours in the chair. I hope we're not going to get into any kind of tissue damage. And the next day, everything looks okay. You don't really see anything at the surface, maybe a little bit of erythema, but it's still blanchable, so you think, wow, we dodged a bullet. What you can't see is that in the underlying tissue, you have microscopic areas of ulceration. So you've got some tissue damage. It's just microscopic. That tissue damage can self-repair without any open ulcers developing, so long as perfusion is maintained at a pretty constant rate. But that microscopic tissue damage also increases the metabolic rate of the tissues in that area. So now it's Sunday, we think we got by, just a little bit of blanchable erythema. If we're thinking, we think, increased metabolic rate, reduced tolerance. So we get the patient up again at 10, and that day we get them back at 2. So they've only been up 4 hours, but still longer than they should be up in the chair if they're not able to shift their own weight. What I might see on Monday then is I might see non-blanchable erythema, because that second episode of exposure occurred over tissues that were already hypermetabolic, trying to repair a previous injury. So can repeated insults result in greater level of damage? Absolutely. So you have to be aware of that. Anytime you see even blanchable erythema, what does it tell you? The underlying tissue was compromised. Right now the blood vessels are intact. However, that does it does not mean that the metabolic rate of the underlying tissue has not been increased. So minor trauma, increased metabolic rate, increased vulnerability, and another episode of limited trauma, and you can push the tissues over into frank ischemia and necrosis. Here's the other thing to think about, and that is the impact of soft tissue deformation on perfusion and on tissue viability. You sit on a hard surface. If you were looking from underneath, you would see the soft tissues deformed and compressed. When you deform and compress an area of soft tissue, you deform and compress the blood vessels in that area, and you push blood to the vessels on either side. So remember, in this soft tissue, you've got all these vessels. So if I get point pressure right here, I get a vessel that's partially or completely collapsed in that area. The blood shunts away from the area under pressure. Then I can get ischemia to that tissue. So one approach that has been used in pressure ulcer prevention is to try to minimize soft tissue deformation, to use surfaces that very evenly distribute the pressure so that the pressure is not point pressure, it's exerted across the entire surface. The blood vessels are much more resistant to widely distributed forces than they are to point pressure. It's easy to collapse a vessel at one point. It's very hard to collapse a vessel across its entire length because that vessel's full of blood. Point pressure, the blood moves there and here. Distributed pressure, the blood keeps the vessel open. So you can see the advantage of having a surface that very evenly distributes the pressures. It eliminates or minimizes the effects of soft tissue deformation, eliminates or minimizes those high pressure points that can so rapidly cause ischemia. What about alternating pressure surfaces? How do they work? Well, alternating pressure surfaces do cause tissue deformation. And how they work is they constantly change the points under pressure. So you have a surface that has a series of air chambers. At any given point in time, 1/3 to 1/2 of the chambers are inflated, the other 1/2 to 2/3 are deflated. Okay, so it's like this. Then this chamber goes down, this one comes up. So you're constantly exchanging, alternating the pressure points. The tissue is compressed. You do have soft tissue deformation. You do have vessel compression. But because you're constantly changing those, the hope is and the belief is, and so far the science indicates, that the compression doesn't last long enough to cause tissue damage. That constantly changing the pressure points has the same effect as turning the patient. It restores blood flow. So yes, this tissue is compressed, but in 15 minutes, this air chamber will deflate, this one will come up. This tissue is now perfused. This tissue is compressed. Then this comes down, this comes up. So you're constantly changing the points of compression. And we'll come back to that when we talk about support surfaces. Right now, what I want you to realize is that there's two approaches to pressure ulcer prevention. The most widely used approach is to use a surface that's extremely conformable, that minimizes point pressures, that minimizes vessel compression to maintain tissue perfusion. And we use that in combination with periodic repositioning to totally restore perfusion to that entire surface. There is another approach, and it's the alternating pressure pad approach, where you change the points under pressure on a routine, frequent cycle so that you compress, offload, compress, offload. At this point in time, we lack data that says this approach is better than this. So we have both available to us. So this is what we've been talking about. Two major elements for pressure ulcer prevention. Pressure injury prevention. I keep trying to remember to say injury and not ulcer. You know this. This has been true for many years. We have pressure redistribution surfaces that are designed to minimize tissue deformation, minimize vessel compression, maximize tissue perfusion. We also have the option to routinely reposition the vast majority of our patients, which totally offloads the surface upon which they were lying and transfers pressure to a different surface. When we reposition the patient, we totally restore blood flow, we restore lymphatic flow, we restore interstitial fluid flow. We also have the option to use alternating pressure pads to alternate pressure points. Now here's one thing to remember. If I'm on an alternating pressure pad, I don't want you to think that takes the place of repositioning, because we're changing points like this, but they're side by side, and there's some overlap in the underlying tissue. So yes, you're constantly changing the area of tissue that's being compressed and restoring perfusion here, then restoring perfusion here. But you still need to turn that patient to totally offload that entire surface, to totally restore lymphatic flow, interstitial flow. So use of an alternating pressure pad does not eliminate the need to reposition that patient. Now I want you to know current terminology. You're going to hear this again when we get to support surfaces. Pressure relief means that the surface was totally offloaded. It means I turned the patient. So if I've provided pressure relief to the right side, I turned the patient, probably to the left. If I have provided pressure relief to the heels, I have offloaded the heels. I have them off the bed surface. Pressure redistribution means that I have evenly distributed the pressure along a larger surface. So if I have you on a pressure redistribution mattress, that is going to be a mattress that evenly conforms to your body so that your body weight is evenly distributed across the entire contact area. It's designed to minimize soft tissue deformation, minimize point pressure, maximize perfusion. And alternating pressure is a mattress that's connected to a pump that constantly changes the pressure points. Let's talk about shear force. So we've talked about what we can do to minimize the negative impact of pressure. Let's talk about shear force, how it works, what we can do to minimize the negative effects of shear. This is what happens with shear. It's an interface, or it's the conflict between friction forces, which tend to hold us in place, and gravitational forces, which tend to pull us down. So you take a patient who's lying supine with no head of bed elevation. You know how patients get kind of locked in and it almost feels like they're sticking to the sheets? That's the effects of friction. Friction is the interaction between two surfaces that tends to hold that patient in position. Friction also refers to surface rubbing. Okay, so friction tends to hold me like this. Then you elevate the head of the bed, and now you've introduced gravity. So gravity tends to pull me down, but friction tends to hold me stable. How does that conflict get resolved? Well, what happens is that the surface of the skin remains adherent to the sheets. It's kind of like the skin sticks to the sheets. It's like I'm with you. The deep tissue layers, the muscle and the bone, move in response to gravity. So muscle and bone shift down, skin remains adherent to the sheets. What happens to the subacute tissue? it gets caught in between. That's where shear occurs, the tissue layers sliding against each other. What happens to all the blood vessels that flow through the subcutaneous tissue layer? They get compressed or torn or angulated. So friction causes the skin to adhere, gravity causes the deep tissue layers to move down, and the intervening tissue layer is the subject of the shear force. Pressure and shear in combination are much more damaging to the tissues than pressure alone. Some studies indicate up to 5 times more damaging, because shear can cause damage in any tissue direction. You tear a blood vessel, you angulate a blood vessel, you compress a major blood vessel, and all the tissues supplied by that blood vessel are damaged. How do I know that it's a combination of pressure and shear? First of all, location is a big indicator, because it's going to involve an area that it was exposed to both pressure and shear. And the reason I put this in is because the sacrococcygeal area is an area very commonly exposed to both pressure and shear when the head of the bed's elevated. This just shows you that with pressure alone you get this. You get just flat compression. But with pressure and shear, you get compression and then stretch. So here you see you've got downward force, and now you've got lateral force. And that is much more damaging to the underlying tissue. What we see clinically, we see wounds with undermining, tunneling. We see irregular, elongated wounds. Those findings strongly suggest a combination of pressure and shear. So shear is very damaging. We don't want our patients exposed to shear. And yet, what percentage of your patients require head of bed elevation? What about in the ICUs? What about your patients who are on vents and they're on VAP prevention protocols? They require a minimum of 30 to 45 degrees head of bed elevation. That's going to place the sacrococcygeal area at tremendous risk. In trying to prevent shear force, we have one of two choices. We can try to prevent sliding, because that's when shear occurs, is when the patient slides. But it's almost impossible to totally prevent sliding when the head of the bed is elevated. So the alternative is allow the patient to slide, but stop the drag. How do we stop the drag? We eliminate those frictional forces that tend to hold the person in one position. So we put them on a very slick surface so that when they slide, all tissue layers slide together. So here's our strategies. Here's what we want. We either want you not to slide, or we want you to slide without any drag. So when you were a kid, do you remember going down a sliding board? And if you had on long pants or if you had wax paper, you just slid without any kind of drag. But if you were hot and sweaty and in shorts, do you remember going and only your young tissue saved you? So we want them sliding without drag if they slide at all. What can we do to minimize sliding? Well, we can keep the head of the bed as flat as possible, as flat as is therapeutically tolerated. We can gauge the knee to help reduce sliding. Some people have been taught don't use the knee gauge because it's going to compress the popliteal arteries. But in reality, you can use the knee gauge safely. You can partially raise the gauge without compromising the popliteal space at all. When they're in the chair, there are cushions that are elevated in the front so that it keeps the patient sitting back and keeps them from sliding forward. You can put them in athletic shoes when they're in the chair so they're sitting with their feet flat on the floor. So these strategies are used to reduce sliding. We should always be using lift sheets or heavy-duty underpads to lift our patients so that we're not dragging them. But here's the most important strategy. We have the option to use either a support surface or to use therapeutic linens that minimize shear force by minimizing friction. So we can use low friction support surfaces, low friction linens. And what that does is it allows the person to slide down without causing all of that drag. So I remember when low air loss surfaces with Gore-Tex covers first came out, and people were very concerned because the bed looked so untidy, because the sheets wouldn't stay in place, the patient wouldn't stay in place, but their skin looked much better. So that's the point. If they're going to slide, you want all tissue layers to slide together. So we talked about the negative impact of prolonged or high intensity pressure, vessel compression, tissue ischemia. We've talked about the negative impact of shear, vessel compression, and angulation resulting in tissue ischemia. Now we're going to talk about the effects of compromised tissue tolerance. So you know that you might have two patients in an ICU, bed 1, bed 2. And one patient might be much more susceptible to pressure injury than the other. Even if they're the same age, the same gender, maybe they have much of the same pathology going on. But the patient in bed A is malnourished and underweight, whereas the patient in bed B is 20% overweight. The patient in bed A is febrile, the patient in bed B is afebrile. Patient in bed A is hypotensive on vasopressors and septic shock, the patient in bed B is not. So obviously the patient in bed A is going to be much higher risk. So there are things that make someone much more vulnerable to the effects of pressure and shear. And they're listed. So if I have a patient who's cachectic, has low, very low BMI, like this lady, why are they higher risk? Well, they have no soft tissue. They have no ability to evenly distribute their weight. All of their weight is going to be supported by bony prominences. So very easy for them to rapidly develop severe tissue ischemia. This lady had Crohn's disease. She gave me permission to use her face in the slide. At this point in time, she had no breakdown. But as you can see, she has no soft tissue, no fat, and major muscle wasting. If she became septic and required emergency surgery and ended up in ICU, how long would it take before she developed severe breakdown unless we did very, very high-level prevention? And the answer is not long. I'd much rather have a patient 10 to 20% over their ideal weight than have a patient 10 to 20% under their ideal weight. So any patient who's cachectic, who is malnourished, who has low BMI, at risk. Patients who are febrile, because fever elevates the metabolic rate, they use oxygen at a faster rate, their tissues become ischemic at a faster rate. What about patients with pre-existing vascular disease? So even at baseline, their perfusion is compromised. What if they're third spacing and very edematous? That's negative because now the oxygen has to get through all that fluid to get through the tissues. And edema can further compromise, further compress the capillary bed. So edema compromises perfusion. Vascular disease compromises perfusion. What if the patient's hypotensive? What if they're having to use multiple vasopressors just to keep their mean arterial pressure in a relatively safe range? And what about the effects of vasopressors themselves? What do they do to the peripheral circulation? They shut down peripheral blood vessels. So how many of you have had patients with necrotic digits because they required vasopressors? If you have a patient who's in septic shock, hypotensive, on vasopressors, what does that do to their risk for pressure injury? Significantly increases it. smoking, many negative pathological factors associated with smoking. So smoking increases your risk. Physiologic stress, which that applies to every one of our patients, also affects your risk. So if I have a patient who's much higher risk at baseline, what can I do? There's nothing magic. It's just that I need to be aware that this patient, even though their Braden scale looks comparable to the patient in bed 2, this patient's much higher risk because they're febrile, cachectic, hypotensive, and on vasopressors. So it means I have to be much more vigilant with my prevention protocol. Okay, let's talk about what happens at the tissue level when a patient develops a pressure injury. We're going to talk about normal response to short-term tissue occlusion, vessel occlusion. Then we're going to talk about pathologic responses. So let's say I've been sitting in the chair for between 1 to 2 hours. If you could crawl underneath my chair, you would see areas of clear-cut tissue ischemia where the vessels are compressed. And you would know that the tissue in that area is ischemic. But remember, short-term ischemia, well tolerated. So let's say the tissues have been ischemic for somewhere 30 to 45 minutes before you get there to reposition the patient, help them shift their weight, move them back to bed, whatever. Okay, so when you compress tissues, you're going to get reduced blood flow or possibly total absence of blood flow to the area of tissue being compressed. If you could look through the bed, you would see areas of pallor corresponding to the tissue area being compressed. What you could not see is that the blood vessels in that area are dilated because they're trying to increase perfusion. So whenever you have an area of tissue that becomes ischemic, you release a lot of substances that cause vasodilation, the body's attempt to improve blood flow. You can see pallor, tells you the vessels are compressed. You cannot see the dilated vessels. But as soon as the pressure is eliminated, is relieved, as soon as you turn the patient off of that area, so you turn me from supine to sideline, you get me out of the chair and put me back in bed, you can see what happens next. As soon as you relieve the pressure to the area, blood rushes into those dilated vessels. And what do we see clinically? We see blanchable erythema. Blanchable erythema is tissue CPR in progress. Rapid delivery of blood, oxygen, nutrients to the tissue that has been compressed. Pickup of carbon dioxide and waste products. Totally normal. What are the 2 parameters that I should be using to evaluate whether this is a normal or abnormal finding? First of all, it should be blanchable, so when I touch it with my finger, it should go white. When I relieve the pressure, the redness should come back. That tells me vessels are intact. I can compress it. And secondly, it should resolve in less than an hour. So if I turn you at 2 o'clock from supine to your right side, and I see that area of hyperemia, but I touch it and it blanches, I come back at 5 o'clock to reposition you, that erythema should be long gone. If it's still there, it's no longer a normal response. Now, let's talk about what happens when you develop significant tissue ischemia that is not reversible. Let's talk about irreversible tissue ischemia. What's going on at the cellular level? Well, remember, you've got tissues that are compressed, you've got a marked reduction or total obliteration of blood flow, which markedly reduces or eliminates oxygen delivery to the tissues. When the tissues become oxygen hungry, they can no longer maintain aerobic metabolism, which is normal. They're forced to switch to anaerobic metabolism. And that's the first step in a very sick cell. We're moving toward sick cells. So you've switched to anaerobic metabolism. Now what happens? Well, now your ATP levels drop. When your ATP levels drop, it impairs the potassium sodium pump. So now it allows potassium to move out of the cell. Remember, potassium is normally inside the cell. And it allows sodium and calcium to move into the cell. Okay, well, does anything bad happen when potassium moves out, sodium and calcium move in? Yes. So now you've got hypokalemia within the cell, which adversely impacts metabolic functions of the cell. You've got sodium within the cell causing intracellular edema and making the cell leaky. You've got rising calcium levels inside the cell, which causes production of oxygen-free radicals and other inflammatory mediators that further damage the cell. Bottom line, as soon as that cell is forced to switch from aerobic to anaerobic metabolism, you set into place a number of microscopic processes that make the cell progressively sicker until it dies. So what's the end result of tissue ischemia? Cell and tissue death. In addition to ischemic injury, remember, there's the potential for reperfusion injury, where you form microthrombi that block distal vessels and cause ischemic damage all over again. Also, reperfusion injury involves the negative effects of oxygen-free radicals to the endothelial lining of the vessels. You get lymphatic dysfunction. So when you compress the capillary bed, you're also compressing the lymphatics. That compromises their ability to pick up fluid and return it to the bloodstream, and causes progressive edema and waste accumulation. So you've got ischemic injury, you've got reperfusion injury, you've got lymphatic dysfunction, and recent studies suggest that mechanical force can directly damage the cytoskeleton of the muscle cell. Soft tissue deformation, high pressure against the muscle cell. So in addition to the negative impact of ischemia, negative impact of reperfusion injury, negative impact of lymphatic dysfunction, you might get primary direct mechanical damage to the muscle cell. If the tissues move into ischemic injury, so now we've moved past well-tolerated short-term ischemia with no negative effects. That was reactive hyperemia that resolved on its own. Now we have tissues that sustained significant oxygen deficits that were forced to move into anaerobic metabolism, that may have sustained reperfusion injury, that were affected by lymphatic dysfunction, may have sustained some direct damage to the muscle cells. Okay, so now we've crossed the line. We have some definitive damage to the tissues. What do I see clinically at the surface? There's two things I might see. If I actually have some degree of underlying tissue damage that's not reversible with restoration of blood flow. The first is an inflammatory response. So now we've gone from a normal blanchable erythema that resolves on its own pretty quickly to a non-blanchable persistent erythema of the involved tissues. What causes this? Well, remember that damaged cells release inflammatory substances that cause persistent vasodilation. So when you have enough damaged cells, you get a persistent vasodilation that's manifest as a stage 1 pressure injury. Non-blanchable, persistent erythema. When I see that, when you see that, you know there's some degree of tissue damage in the underlying tissue. What you don't know is how extensive it is. All of our data today indicate that most of the time, if we intervene promptly and effectively, most of the time the tissues will recover without progressing to frank ulceration, to an open wound. So when I see this, what the staff is going to ask me is, what should I put on it? And my answer is anything except the patient. It's really not what you put on it, right? If you put something on it, I want it to be transparent so you don't lose sight of that area. But the main thing is to be very aggressive in repositioning the patient, make sure they're on the right support surface, keep them off this area as much as possible so that those tissues can self-repair. So most of the time, when you have stage 1 pressure injury, prompt intervention will prevent progression to an open wound. The other thing you might see is a DTI, deep tissue injury. This is indicative of a much more severe underlying injury. You've got damage to the tissue here. You've got greater damage to the tissue here. So you know that deep tissue injury is frequently described as looking like a bruise under intact skin. It tells you when you have this maroon, purple, black discoloration, it tells you you've got vessel damage and that you've got probably some damage to the deep tissues. Many times DTIs progress to an open wound and to significant tissue loss, even with appropriate intervention. Not always, but frequently. For me, the clinician, whether I see this or this, in terms of interventions, it's basically the same. The damage has been done with both of these. Typically here it's microscopic and reversible. Here, it may be macroscopic and it may not be reversible. But either way, my initial focus is prevent further damage. So I've got to look at the support surface. I've got to make sure they're on the best support surface available. I've got to focus on keeping them off the area. If they have a DTI on the heel, I've got to make absolutely sure that they are in a heel elevation boot all the time. If they've got a DTI on the sacrum, I want them turned right side, left side, right side, left side. I want them off the sacrum, if at all possible. Okay. Despite best efforts, it may progress to an open wound because the damage has been done. All I can do is prevent further damage. And these wounds are more likely to occur in patients who had high-intensity sustained pressure. For example, patients who were found down, who fell in their homes on a hard surface and were on that surface for hours or days before someone found them. Or a patient who undergoes a very prolonged surgical procedure and they develop a DTI in the area on which they were positioned. Managing stage 1 and DTI lesions, what can you do? What we've already said. You focus on preventing further damage. I cannot undo what has been done. I can prevent further damage. I can optimize blood flow to the area. So I want them off the involved area if at all possible. I want high-level support surface. I don't want any massage to the area that could add mechanical damage, mechanical trauma to an already very compromised area. Dressings are truly optional. If I add a dressing It's usually to protect against frictional forces. Dressings don't protect against pressure. If I add a dressing, I should make sure it's transparent so people don't lose sight of what's going on. Now, if it's a DTI, there's some work going on to see is there anything we can do once we have a DTI that maybe improves vasodilation, that reduces tissue hypoxia, that might limit the amount of tissue damage. Here are the two guidelines so far. First of all, watchful waiting is the best approach for most DTI injuries. Don't start debridement until you have very clear demarcation between viable and non-viable, because I'm sure a lot of you have seen wounds that started out and they looked huge DTIs, and then the perimeter gradually closed in and you ended up with a relatively small wound. Some DTIs resolve without opening up. So initially, watchful waiting. There's some research that indicates that non-contact, low-frequency ultrasound might be beneficial in minimizing tissue damage associated with DTIs. At this point, we don't have enough data to make definitive recommendations. But as you go to conferences, as you read your journals, you're going to see ongoing studies looking at this issue. And hopefully within a few years, we'll have something more definitive. Now, in the last few minutes in this session, I wanted to talk briefly about medical device-related pressure injuries, which are different than pressure injuries located over bony prominences. So what's the definition of a medical device-related pressure injury? Pressure injuries associated with the use of devices that have been applied for diagnostic or therapeutic purposes. And here's the important thing. The pressure injury that develops has the exact same configuration as the device. Now, these can develop very quickly. Most of them occur in areas with very little soft tissue, so very little ability to redistribute pressures evenly, so therefore rapid development of tissue ischemia. The other thing you should know about medical device-related pressure injuries, some of them involve the skin, and some of them involve mucous membranes, the lip, the oral mucosa. If they involve the skin, they are frequently designated as MDR-S, and if they involve mucous membranes, MDR-ML. You need to know some things that are different about medical device-related pressure injuries when it comes to classification, documentation, and staging. If it is a mucosal membrane wound, you do not stage it, because the anatomy of mucous membranes is different than the anatomy of the skin. So if it's oral, then you simply are going to measure it and describe it, but you will not stage it. In contrast, if it involves the skin, yes, you will stage it. However, you have to be aware that many of your medical device-related pressure injuries occur in areas where there is no subacute tissue, over the bridge of the nose, the pinna of the ear. So in that case, the staging would be modified. You could have a stage 1 MDR-PI, a stage 2. You would not have a stage 3. You could have a stage 4, meaning it extends to the cartilage or muscle. And it could be unstageable, meaning it's covered with necrotic tissue. So staging for skin injuries, but modified. The risk factors for medical device-related pressure injuries are pretty much the same as risk factors for skin tears and for MARSI. Your neonatal and your ICU patients are very high risk. First of all, they're very vulnerable in general, and secondly, they require a lot of devices. So simply the number of devices used on our neonatal population and our ICU population places them top of the leaderboard in terms of at-risk populations. Things that make an individual specifically at risk: sensory impairment. So let's say that I have a splint on my lower leg. If I have intact sensation and I'm alert, and that splint is causing pressure and tissue ischemia, I'll know it, and I'll complain. And I'll tell you, get that off and check to see what's wrong with my ankle. Something's going on with my ankle. But if I have that same splint on, same level of tissue ischemia, but I've also got neuropathy, or I'm sedated, then I will be able to appreciate the fact that my tissue is becoming ischemic and injured. I won't be able to report that. And it will be totally up to you to monitor what's going on with me and to intervene appropriately. So sensory impairment, a big thing. Or compromised ability to communicate pain and discomfort. So your neonates, they might be restless, but do you know it's because of pain related to this device? You just have to be very thorough in your assessment. What about a demented older patient? Might not be able to tell you what's wrong. So we're going to come back to the importance of routinely assessing the skin and soft tissue under medical devices to make sure that that tissue is healthy and that nothing negative is going on. What about morbid obesity? Why is that a risk factor? Well, devices can get buried in body folds. Tubing can get buried in body folds. Tubing can get compressed under a very heavy leg and you might not know it. Things can get lost in the bed, embedded in body folds, and we might not even know it for a little while unless we're very meticulous in our monitoring for these patients. So, morbid obesity for obvious reasons, edema in the area of the device. So maybe when they put this device on or in, it was correctly sized and correctly stabilized, but now I have soft tissue swelling and all of a sudden the device is buried in the tissue, pulling against the skin and causing localized ischemia. In correctly sized devices, this is particularly true of stockings. So if somebody just looks at my leg and says, oh, I think she needs a small, but really I need a medium-sized stocking, and they put me in a small stocking, what happens? I get tissue compression, and if I cannot report it, then I can get ulceration. So carefully sizing devices that are patient-specific, that need to be sized. Cervical collars need to be sized. Stockings need to be sized. Probably the number one risk factor is that we are so focused on so many other things that we're not really monitoring that device and the skin under the device. And maybe we're not providing the necessary preventive care because we're so focused on preventing ventilator-associated pneumonia and pressure injuries over bony prominences and catheter-associated urinary tract infections and falls, et cetera, that I totally lost sight of checking the skin under those stockings, checking the skin under that splint, checking the skin under that collar, under that trach. The pathology for medical device-related pressure injuries is much the same as pressure injuries over bony prominences, but a little bit different. Localized pressure associated with medical devices can cause localized ischemia that's top down, not bottom up. And here's why. So you think about perfusion to the skin. So here's your epidermis, here's your dermis, here's your blood vessels. If you put a device right here and it compresses the tissue right here, it can literally collapse these blood vessels and shunt blood here and here. The deeper tissue layers are not affected. They're not compressed. Muscles not compressed. Subcues not compressed. The only tissues compressed by this device are epidermis and dermis. But they can create very localized pressure points and soft tissue deformation. that collapses the blood vessels in that area, and specifically collapses the blood vessels to the skin in that area. So you can get a top-down ischemia affecting only the skin layers. That does not happen with ulcers over bony prominences, because with ulcers over bony prominences, all soft tissue layers are compressed at once. And remember, the muscle layer is most vulnerable. Maceration can play a role because a lot of times moisture accumulates under these devices and renders the skin more vulnerable. And sometimes you get friction because the device doesn't fit well, so it's rubbing back and forth. So you can have a combination of friction, maceration, and pressure. What we know is that just like everything else, most of these wounds can be prevented. Probably almost all of these wounds can be prevented. And it comes down to some pretty simple things, okay? So we're going to go through what we need to do and what we have available to us to prevent medical device-related pressure injuries. We have so many things available in 2016 that we did not have a decade ago. So first of all, if it is a patient-specific device, like a cervical collar, like support stockings, they need to be sized correctly. So we need to follow guidelines in sizing them. And then we need to check to be sure we have an appropriate fit, that it's not cutting into the tissues or moving back and forth, causing friction damage. So fit correctly if applicable. You want to secure all devices without tension. So when I'm securing a tracheostomy tube, I want that tracheostomy tube held securely in place within the trachea, because I do not want to get into respiratory compromise. But do I want my trach ties to cut into the skin and to cause a lot of tension and pressure on the surrounding skin and even on the trachea itself? No. I do not want tension. Tension will always cause trauma. So I want to fit devices correctly. I want to secure my devices correctly, but I do not want to create tension. That's the source of injury. Look at all of the things that we have available now. So we used to tape endotracheal tubes either to the mouth, to the nose, and we got a lot of trauma to the lip or to the nose. But now we have commercial devices that are designed to stabilize the endotracheal tube, hold it in position within the trachea without causing trauma to the nose, without causing trauma to the mouth. Secured with hydrocolloids to each side of the face. We should look at using protective dressings to minimize the negative impact of the device on the underlying soft tissue, to minimize that soft tissue deformation and point pressure. So what are some things that are out there? Well, we routinely use foam dressings under tracheostomies, because that minimizes point pressure on the underlying tissue and absorbs moisture and helps to minimize friction. What about our padding for our oxygen tubing, our oxy ears? So that we're not getting tubing rubbing against the ears. Now they're protected by soft foam. So our padding makes a big difference. There have been studies done that have shown that routine use of appropriate foam pads under or around devices significantly reduces the incidence of medical device-related pressure injuries. So in all of these, you see appropriate securement devices that prevent tension against the nose, against the mouth, against vulnerable tissues, while holding the device in position. One thing I want to say about dressings. So they've actually studied several categories of dressings. They've studied foams, solid glycerins, hydrocolloids, and transparent adhesive dressings. And all of them reduce the incidence of medical device-related pressure injuries. But dressings that had padding and absorptive properties like foams and To a lesser extent, hydrocolloids, really foams were the most effective in reducing medical device-related pressure injuries. Makes sense that foams would be particularly helpful because of that padding effect and their ability to control moisture. If you're going to place a dressing between a device and the skin, so let's say you're going to put a dressing under a trach, under a PEG tube, you want to make sure that there's room for that dressing. If there's not room and you cram the dressing under the trach, okay, or around the trach or around the PEG tube, then you're just adding to the pressure. So if I'm putting something around a trach, I need to release the trach ties enough to get my dressing in place, re-secure my trach ties to make sure I don't have excessive tension. If I have a PEG tube with a silicone disc and I feel like I need padding under the silicone disc because there's some moisture, because it's trying to dig into the skin, then I need to advance that silicone ring just a little bit, put my dressing down, and then put the silicone disc back in place. Obviously, we don't want to put any of our patients on lines, on catheters, or on bed trash. Bed trash is actually a category of medical device-related pressure injuries. So how many times do we roll a patient over and say, oops, I didn't know that was in the bed? Major implications for us that every time we turn a patient, we need to make sure that all lines are clear, that we did not position the patient on the Foley, we did not position the patient on the bowel management system, on any of their IV lines or tube feeding lines. We need to be sure all of our lines are clear, that there's nothing left in the bed with the patient. And then very, very important, we've got to monitor the skin under those devices. So every day, every shift, we should be checking to be sure that the skin under that device is intact, that there's no problem. If I see a problem, I need to modify my management of that device. So stockings should be removed every shift so that we can inspect the skin, inspect the heels, and then we can reapply them. They shouldn't be left on day after day after day. Whenever I give trach care and I change out my dressing around the trach, I should release the trach ties, make sure that the skin all the way around is intact. Patients with cervical collars, we should release the anterior side and clean and inspect, then release the posterior side, clean and inspect. We need to be monitoring the skin under our devices just like we monitor the skin over our bony prominences, which requires a change in mindset. And then the last thing, just to bring prevention down to specific tubes, basically prevention involves size correctly, pad when indicated, reposition if possible, and inspect on a routine basis. So ET tubes, commercial stabilizers that protect the face and the lips, you saw those. You can frequently reposition the tube within the mouth without changing the depth of the tube, just to protect the oral mucosa. And then combine skin inspection with oral care. NG tube, protect the skin with a liquid skin barrier. Use the commercial stabilization device. Or if you have to make your own, make sure that you're stabilizing the tube without tension. You don't want it pulled up against the nasal septum. Again, reposition the tube every shift if it's putting any pressure anywhere. Oxygen mask, a very common source of medical device-related pressure injuries, so you want to collaborate with respiratory therapy to be sure it's fitted appropriately and that the minimum amount of tension is being used to hold it in place. It's got to work, but we don't want to use more tension than is required. Definitely we need protective dressings to the bridge of the nose, and we need to be monitoring. Collar splints and braces, we should be working with PT to be sure they fit correctly. We should be removing and checking every shift to make sure that the skin underneath is intact. And stockings we've already talked about. So that's the end of this discussion. In our next class, we're going to talk about establishing an effective program for prevention of pressure injuries. We're going to look at prevention from a general perspective and then from a very specific perspective, beginning our admission and walking the patient through. Thank you.